And so we go from impulsivity, which means I see the drug, I want the drug now, to compulsivity, which means I see the drug, I feel anxiety about not using, and so through incentive motivation, I use, the anxiety goes away. All right, so that's pretty much how we describe that. We'll get more into that. Now, if you remember that, excuse me, the other picture of the brain with that neuron track, what I've done here, what this particular graphic demonstrates, is a single neuron. And down here is the bottom of the brain, the ventral tegmental area. And up here is the nucleus accumbens, right here. And that DA refers to dopamine stores, right in there. And basically what we now know, because remember all of the molecules look different, and so they couldn't understand how they all went to the same place. Well, what we now know is that all the drugs of abuse end up at the nucleus accumbens, the ventral tegmental area, and they all follow different neurotransmitters all around, but they all go to the same place. And when those neurotransmitters hit those receptors, it causes depolarization, dopamine gets released, and hits these particular receptors in the nucleus accumbens. So, for instance, when somebody drinks alcohol, alcohol utilizes the GABA system. The alcohol goes up here to the nucleus accumbens, hits the GABA, which causes depolarization, and dopamine gets released. Same thing with marijuana. It hits the cannabinoid receptors. The opiates hit the mu-opiate receptors. Nicotine hits the acetylcholine receptors, and I'll talk about that in a second, what happens there. All the hallucinogens pretty much hit the serotonin, which is abbreviated 5-HT, the serotonin receptors, and PCP hits the glutamate receptors, as does alcohol also. Now, another interesting finding that they found, so the drugs of abuse all kind of congregate here in the ventral tegmental area and hit their respective receptors and cause release of dopamine. Now, the exception to that particular model are the psychostimulants, like cocaine, amphetamine, methamphetamine, all of the prescribed psychostimulants like Ritalin, Vyvanse, Adderall, Concerta. What they do something a little bit different. They bypass this mess. They find their way directly to the nucleus accumbens here, and they actually chemically cause dopamine to be released in large amounts. And so we now know that crack cocaine, because it's delivered so rapidly to the brain, is the most addictive substance. Crack cocaine is right now the most addictive substance because when it is inhaled, it bypasses all the mechanisms in the body and goes from the pulmonary system directly into the brain, right to the nucleus accumbens, and rips out a whole bunch of dopamine. And that causes such a significant high in the person that there are plenty of cases of people that become hopelessly addicted after just one single use of crack cocaine. That's how addictive it is. Now, nicotine is an interesting substance here. What's that?
Yeah, the nicotine is the most addictive.
Well, that's only because more people use it. But it's more readily available, and it's a illicit substance,
Yeah.
right? So they say it's the most addictive because more people use it. Well, that's not how you grade it, you know. We look at how fast, from the point of use to the point of chronic addiction, does the drug cause, and that's how they determine that. But nicotine. So what happens with all of these other drugs is the more the person uses, the more it causes release of dopamine. That just makes sense. Now, nicotine is a little bit different. So nicotine hits the acetylcholine receptors here. And so what happens, and the tobacco industry knew this way before addictionologists knew it. And that is that when nicotine hits these receptors, in 98% of people that smoke, that receptor desensitizes. None of the other receptors desensitize. The more you hit them, the more they end up releasing dopamine. But nicotine, that receptor right there, the acetylcholine receptor, desensitizes. And the tobacco industry knew for years and years and years that 98% of the folks, it takes one. Everybody always asks, how did they come up with how much tobacco to put in a cigarette? How did they come up with that? Was it random? Everybody would say it's random. They just happen to do it that way. No, it's not. What they determined is that the vast majority of people, after one cigarette, the receptors in the brain, the acetylcholine receptors, are desensitized. All right. Now, how did they prove that? I'm sorry?
Why is that? That that's the only one that desensitizes?
No, nobody really understands that. Nobody knows why that is. But that's only 98%. There's 2% of the population in which that doesn't desensitize. And the more you smoke, the more it releases dopamine. They're called the chain smokers. Right? The more they smoke, the more they feel good. But for 98% of the population, and behaviorally we see them, these are the folks who get up in the morning, have a cigarette, go to work, they have to have a cigarette break. One of the things we also know is that that receptor, when it desensitizes, it takes about 3 to 4 hours to turn it back on. And that's exactly the time that people start craving a cigarette break. Right? Every 3 hours or so, people say it's time. I mean, wherever you work, I know where I work, they get up in droves and just head out to have that cigarette. And they go out and have that cigarette because as that is resensitizing, the cravings turn on, they get up and go out and have their cigarette. Some people may need 2, but most people only need 1 cigarette to desensitize it again. They feel good, they go back into work. 3 to 4 hours later, they got to go back out for another cigarette. That's how it works, right? So, and then remember, and then we have the small percentage of folks in which it doesn't desensitize, and they're the chain smokers. The more they smoke, the better they feel. Right? So that's an important consideration, another thing to remember. Okay. Now, the body makes its own psychotropics. It makes pretty much analogs, drugs that look exactly like the drugs of abuse. It makes its own morphine, so we call it beta endorphin. You know, when somebody is involved in a trauma, bone breaking or major laceration or something, immediately beta endorphins are released, and the person doesn't feel pain right away. It's not until all the endorphins are used up that we actually feel pain. All right, so we make our own morphine, and that's evolutionary. The purpose of that is back in a million years ago, when the cavemen were injured. It was self-preservation, not to feel the pain so they could get out of the way of harm. If you're laying there feeling all that pain, you'd be paralyzed, you wouldn't be able to move. So the endorphins saturate the brain so that we don't feel the pain, but only for a short period of time so that we can get away. That was the evolutionary purpose of that. And we make our own marijuana too. It's called anandamide. The brain does that too. So it even makes its own antidepressants, anxiolytics, and it makes its own hallucinogens, believe it or not. So if I, yeah.
When does the body make its own marijuana? So we know it produces beta endorphins as a result of the trauma, but when does it produce this, can you say that again?
Anandamide.
Anandamide?
Right. They believe now. See, anandamide was only discovered maybe about 10 years ago. Okay. They never even knew that was in there. Okay. But they believe that it has something to do with the whole a hunger craving. You know, and like eating disordered people, they say the anandamide levels are off. So they're doing the pharmaceuticals companies are doing a lot of studying around using the cannabinoid receptor and anandamide to regulate eating disorders and all that type of thing.
So our heart rate's reduced?
Yeah.
Okay.
And then hallucinogens. So if I ask you, close your eyes and imagine your living room, you can do it. A lot of people can even do it in color. Well, how do we do that? That's the brain releasing hallucinogens. Children release them a lot more frequently and more commonly than adults. We tend to decrease our use in that. Children that have imaginary friends, you know, all that, fantasy world and all that, that's because they release hallucinogens in their brain naturally to be able to do that. Very creative people, artists do that. They can release a lot of the hallucinogenic drugs in the brain so that they can visualize something that's not there. That's the definition of hallucination, right? Something that's not there that we see or hear. But our brain is able to do that. So the basic rule is, if a drug of abuse can hit a receptor in the brain, there must be a natural drug in the brain that hits that receptor. So there are some drugs of abuse out there that we don't call them drugs of abuse because we don't have receptors. For instance, catnip. Only a percentage of cats have a receptor for catnip, and it drives them insane, right? We can use as much catnip as we want. It doesn't do a thing to us because we don't have any receptors in our brain for catnip. So it doesn't do anything for us. There's also a percentage of cats that don't have it also. So you give them catnip, they don't do anything, right? So it all comes down to what receptors we have in our brain and how drugs will relate to that. And so we often, so the drugs mimic the natural neurotransmitters. We have to have the neurotransmitter and the receptor in our brain for a drug of abuse to do what it does. If we didn't have that, it wouldn't do anything. So drugs are often discovered prior to the natural neurotransmitter. For instance, we knew about morphine before we even knew about beta endorphin. So we never really understood when somebody is in a motor vehicle accident and they don't feel pain for a couple of minutes. Nobody really understood what that was. No, we called it shock. We said people were in shock, that's why they didn't feel the pain, without really understanding what was causing the pain. So now we know it's the beta endorphin, but we had morphine way before we knew about how the brain deals with that. We knew about marijuana before the discovery of the cannabinoid receptors and anandamide. We had Valium and Xanax on the market before we knew about the benzodiazepine receptors. Right? So science was never able to figure out how these drugs of abuse work. It's only quite recently that this has all come into the literature. Right? We knew about Adderall and Prozac before the discovery of the serotonin transporter sites. So on and on and on. I remember in my undergraduate nursing days when I took pharmacology, quite simple then, because we had to learn the therapeutic use of the drug, the side effects, the dosage, and when we got to mechanism of action, unknown. We didn't know how any of those drugs work. Today there's still a lot of drugs that we still don't have a clue, their whole story. Aspirin. We don't know exactly how aspirin works. We know part of the story, but we know it does a lot more different things than what we even know. All right, so we test these drugs, the pharmaceutical companies do, and then they look to see what happens. And then they worry about how they work later. So, and that's still true. Even today, although we know a lot more about mechanism of action, some of the newer drugs, they'll say, if you read the inserts, they'll say, we think it does this or it does that. But there are also unknown mechanisms for those drugs. Okay, so the transition to addiction. This is what a lot of people have some trouble with. Okay, taking drugs begins as a voluntary choice. So there's always infighting amongst addictionologists and all of us in the profession about exactly do people have a choice or not. So I was just at an international conference 2 weeks ago in Scotland, and one of the speakers is now pushing the whole fact that addicts always have a choice to say no. And then he gave what he believed technologies from all over the world just sat there in silence, listening to this. But he's actually putting out a book. He says it's going to be out at the beginning of next year with more scientific proof that addicts really do, it really is a choice for them. But currently, the belief is that initially, when the person first starts using, it's a choice, experimentation. I can choose to try it with my friends, or I can choose not to. After that period of trying it, as time goes on, the current belief is that it's no longer a choice. It becomes involuntary. So it begins as a voluntary choice to seek a pleasant stimulus, but for addicts, the choice is no longer volitional, even in the face of terrible personal consequences. And the theoretical constructs behind that are quite interesting. So what happens during the stage of addiction in the brain? Well, the pleasure derived from the various drugs when they activate the brain's reward system promotes continued drug use. So there's the acute reward. I use it, I feel good, I want to use it again. That's how it starts. Repeated exposure to drugs induces the brain mechanism of dependence. And dependence, basically, from a neurological point of view, just means the brain structure is changing as a result of the drug use. So, and we've always known that stimuli or absence of stimuli changes the brain. Children that are born blind and children that become blind after a period of time, their brains look different. And as time goes on, their brains change as a result of the blindness. We know that. We know that children that are not nurtured as infants, their brain has changed compared to those that have been nurtured. So we know that what goes on in our environment changes the brain structure. So we're just applying that same thing to drugs. So dependence leads to daily drug use to avert the unpleasant symptoms of drug withdrawal. So this is what happens after a period of time. So after the person with the addiction has been using over and over for a long period of time, they deplete all their dopamine stores. So no matter how much they use, they don't get that high that they got in the beginning. So what do? Well, they say, either I can't afford it anymore, it's not doing any good, I'm going to stop. As soon as they stop, they go into withdrawal. So what did they do to prevent withdrawal? They use. So now, somebody that's been in an active addiction for 5 years, 10 years, 15 years, the main reason for continued use is to prevent withdrawal. Further prolonged use of drugs leads to more long-lasting changes in the brain that underlie the compulsive drug-seeking behavior and related adverse consequences that are the hallmark of addiction. Now, the whole issue comes down to craving. Now, here's in every specialty, we have our own terminology. It's what makes us a specialty. We own terminology. And we have some terms that are similar terms to what are used in the general population. Craving is one of them. So if I say to you, tell me about craving, what you probably will think about or say is that, well, craving is if I feel like a piece of chocolate or a piece of pie or ice cream, something that somebody's talking about, or I see it on TV, I want it. That's the whole basis of marketing and TV commercials, is to turn on that craving for whatever it is that they're trying to sell, so that it'll be in your mind to get it at some point. That's how all that works. Craving and addiction, even though it's the same word, is quite different. So the craving that you have for chocolate or ice cream or apple pie or whatever it is a psychological craving. It's psychological. It's cognitive, right? It's not a feeling, it's a thought. Addictive craving is physiologic. It is a feeling. not a pleasant feeling. So if I were to ask you, for instance, okay, you're in the mood for a piece of chocolate, is that thought painful? No, it's not. It's not painful at all. It's a thought that you have. Oh, I happen to have chocolate ice cream in the refrigerator. I think I'll go out and get it then. It's purely cognitive in that respect. Craving for drugs in addiction is physiologic. It's a feeling. And it's a bad feeling. Whenever I explain to the general public about the addictive craving, I tell them it's like having a migraine or a tooth abscess. The person can't focus on anything else. So just imagine if you suffer from bad headaches or migraines, or even had a tooth abscess, everything else in your life kind of stops because you're so focused on getting rid of that pain. I know when I was younger, I used to suffer from migraines. And when I would get them, I'd be in my office, for instance, they could happen at any time. I'd have to close the door, shut off the lights, turn off my phone, and lay on the floor until it went away. I could do absolutely nothing. Same thing with craving, addictive cravings. The person becomes so focused on that, they know the only thing that will get rid of that craving is the drug that they have been using. Nothing else. Nothing else will get rid of it. That's what makes it involuntary. The fact that craving is physiologic and it's a feeling as opposed to the craving for chocolate, which is psychologic and is a thought. So that's different. So we have, they've been able to identify different types of craving, cue-based and state-based cravings. Cue-based is a response to an environmental cue. So here, the big book talks about people, places, and things. Right? That is a cue-based craving. The cue creates an internal state which is recognized as craving. It's most notable in cocaine and nicotine. And then state or stress-based craving is an emotional tone, a level of perceived stress, and the craving appears to emerge out of difficult emotional states, most notably in alcohol and sedatives. Now the bad news is that the opiates have both types of craving, both cue-based and state-based cravings. But whether it's cue-based, state-based, or whatever, it's science, it's not behavioral, it's not reality. When it comes to treating, the fact is somebody's had a craving for whatever it is. We got to deal with it. We got to help them with that. Okay, so stressors trigger drug cravings in addicts. One of the things that in treatment that we want to do is get people to learn how to tolerate other people and tolerate their own feelings. That's basically what we want to do with them, because it's I can't tell you the number of patients, usually alcoholic men. I'll ask them about their triggers, and they'll say, if you were married to who I'm married to, you drink too. So basically what they're saying is, I have such stress in my life that the only thing that really helps is alcohol. So what we need to do with our patients is get them to learn to tolerate other people and also to tolerate their own feelings. That really is what it comes down to. The cortisol thing, you can certainly read when you read about this. I'm not going to spend too much time on talking about that. So the nervous system is a complex wiring diagram. We kind of changed subjects here. 100 billion neurons make over 100 trillion synapses in the human brain. So basically the slide just says the brain is very complicated. And so addiction is very complicated. We try to make it simple so we can understand it, but it's still very complicated. And here's an actual neuron that was caught on tape, and what it's really showing is that the neuron is firing, right? That's what the glow is. It's actually depolarizing. And as you can see, the depolarization is moving in two directions. It's moving down that way, and it's also moving this way. And what's happening here is the electrical impulse travels down, that's what's lit up, and then right here is the synapse, and it's right there that the neurotransmitter gets secreted. We can't see that coming out, but then it hits this neuron, which causes depolarization again, and just travels down. So that's how the whole process of depolarization works from neuron to neuron. It goes from electrical to chemical to electrical, and then again to chemical, is the way it goes. So the neurons send electrical impulses from one part of the cell to another part, and then once they get to the end, they release the neurotransmitter, and it goes to the next neuron, which then causes the electrical impulse to move down and down. Oops, I think I went too far. Fast versus slow, I'm really not going to spend any time on that, and the scientific names. But there are dozens of neurotransmitters in the brain. We even believe there are hundreds and hundreds of them that have yet to be discovered. Or like anandamide. They never knew about anandamide until about 10 or 15 years ago. You know, and they're also finding substances in the brain that they don't have a clue what it does. So they believe that they're neurotransmitters. They don't know what they do or anything like that. So there are hundreds, probably even thousands of brain chemicals that we don't have a clue what they even do. So the neurotransmitters basically that we deal with in psych and addictions are broken down into really 5 categories. The cholinergic or acetylcholine, the monoamines, which is norepinephrine, dopamine, serotonin, GABA and glutamate. Now the enkephalins, that turns off the pain, and substance P creates pain. So they identify, so when we experience pain in any part of our bodies, what they were able to identify is the brain releases a neurotransmitter that tells the brain, that tells us you're experiencing pain. And so I guess some very dull person, scientist, named it substance P, P for pain, rather than giving it a more descriptive name. They just call it substance P. So anytime you feel pain, when you break a toe, when you get a paper cut, anytime you feel pain, again, another thing that I can say about you is that substance P has been released in your brain. And I'm sure you've all read about or heard about those kids that don't experience pain. That you could chop off their legs and they don't feel a thing. Again, nobody knew what was going on. Now they know the brain can't produce substance P in those kids. So they don't feel any pain. So they have to be totally 100% protected from falls or anything like that. So then the fifth, there only used to be 4 categories. Now we've added the 5th, the lipids, and anandamide is the other neurotransmitter. Now the other thing that only quite recently they've been able to identify is, so basically the story always went, a neurotransmitter hits a receptor and it causes a reaction, right? Now, and so we can also apply this to addiction. So we know that happiness is on a continuum. We can be content or satisfied, or we can get hysterically laughing for whatever reason. How do we experience that? And they never knew how that continuum related to the neurophysiology in the brain. Well, now they know that the brain is able to release different concentrations of neurotransmitters in what we call a cocktail. So for you to laugh hysterically at a comedy on TV basically means that several different neurotransmitters are released in a proportionate amount to create that level of glee. Same thing with sadness. It's not just the absence of serotonin, dopamine, or norepinephrine. So in the beginning, we used to think depression is caused by a decrease in the amount of serotonin in the brain. And that's what they said. But then we discovered the SSRIs, Prozac was the first one, and they identified that very depressed people that took Prozac, only 60% of them got better. Well, that was proof enough that it's not just serotonin. There must be something else going on in the brain causing depression. And that's when they discovered, well, dopamine plays a role, norepinephrine plays a role. So as time goes on, they're finding more and more of not only neurotransmitters, but the balance of the neurotransmitters. So, and we've known, for instance, in Parkinson's, we know in Parkinson's there's a decrease in dopamine in the brain. And as a result, we see all the symptoms of Parkinson'sism. And so the treatment was, well, increase the dopamine. And so they did that. They increased the dopamine, and people got well. But after a period of time, the Parkinson's symptoms came back. And so they would give them more dopamine, and it wasn't helping. So the Parkinson's was progressing. And then they found out that Parkinson's isn't just a decrease in dopamine, it is balanced by a decrease in acetylcholine. So now they add something. So in Cinemed, it's a combination drug that increases both the acetylcholine and the dopamine, and so they're well for a lot longer. But the interesting thing about diseases that we can't cure is that the mind comes to some conclusion that, for instance, in Parkinson's, the mind comes to some conclusion that it has to destroy all the dopamine in order to survive. So the brain kind of went berserk. And so we substitute whatever it is that the brain has destroyed to correct the problem, but after a while the problem comes back even though we have one of the drugs. But what we now know, we used to say that, well, the person became tolerant of those drugs and the drugs stopped working. That's not what happens. What happens is the body then becomes aware that somehow more dopamine is being brought into the body to correct the Parkinson's. And the body, the mind says, but all this dopamine is poison. We've got to destroy it. So it finds another pathway to destroy the dopamine. And we don't know how that works. So it's always getting back to the belief that that particular person needs to have Parkinson's in order to survive. They end up dying, but the brain is kind of berserk when it comes to that. Okay, co-transmission I'm not really going to talk much about, but when things go wrong in the brain, it can affect any number of these particular things, any one of these sites, drug interactions. We pretty much, in addictions, talk about neurotransmitters and receptors as having problems, but with time, the enzymes and the genes themselves actually change in the brain. So for instance, a receptor problem with ecstasy, MDMA. What happens, especially when teenagers use a lot of ecstasy over a long period of time, what the ecstasy does, remember, it chemically looks like a stimulant, but behaviorally it acts as a hallucinogen. So it acts as a stimulant, and somebody has a lot of ecstasy in their body. What the ecstasy does is actually burn away the receptors in the brain for serotonin. So all the receptors get burned away for somebody to keep using it. And it forms like scabs over that so that the body can't fix it. And what happens for very, very chronic high use is it becomes irreversible and the person goes into a vegetative state. So I've seen several 18-year-olds, 19 years olds that are like vegetables, and it's not reversible. Now, that is a very small percentage of those folks. Usually kids use it in the short run, and they don't use a heck of a lot, but enough to get them high. And when they stop using it, it's reversible. But we still have that handful of folks that it's not. It actually changes the brain structure. Okay, the other thing that happens in the brain is that ion channels open and all of these minerals go in and out and causes, I'm not going to spend any time on this either, but this is what causes the flow of electricity and then the release of neurotransmitters, and the drugs of abuse change the whole process. That's the only point that I want to make on the slide. This just happens to be a graphic of that. And basically what this is showing is that these particular, this is the cell membrane of a neuron. And they have all these little channels in them that open and close. And when they open, sodium goes in, potassium comes out, and everything that's supposed to happen happens right. But a lot of times drugs of abuse do all kinds of crazy things here and causes the rapid shooting of the neurons, the depolarization. Transport carriers, once again, it's a little bit complicated with transport carriers, but once again, so cocaine, for instance, remember I said cocaine goes right through the nucleus accumbens and is able to reach in and pull out the dopamine. Well, it does that by reversing the transport carriers is what happens. So what happens on the neurons? I think the next picture. Yeah, there it is. So this is a graphic of a transport carrier. When dopamine gets released normally, so in a normal situation, dopamine gets released, it hits the receptors here in the nucleus accumbens, and we feel happy, right? And then the dopamine falls off, and what this does is it grabs the dopamine and then takes it back into the cell so it gets repackaged and reused over and over and over again. Well, and so this is the normal process. Dopamine gets released, hits the receptor, we feel happy, it falls off, it gets sucked back up into the cell. Now, when cocaine comes along, what cocaine does is it causes this particular mechanism to go in reverse. So it pulls all of the dopamine out very, very quickly, is how that works. All right, so it's a transport, in the science we call it a transporter problem.
So it pulls it out, but then it doesn't do a reuptake of the dopamine back in?
No, because what happens is it stays there and keeps pulling it out, and there's such a buildup of it, when it falls off the receptors, enzymes come along. I don't have it on this slide, but enzymes come along and destroy the dopamine because it's not being pulled back in.
Okay.
So then all the stores that are inside get depleted.
So it's not being recycled at all, it's just pulling everything out?
Right, it's just pulling it out. And so the neuron has to, so every neuron can make its own neurotransmitters, but not fast enough. That's why we have this system where the neurotransmitters, when they get finished hitting the receptor, get sucked back in so they can be reused. Because we don't make neurotransmitters that fast. It takes a while to do that. And we always need them. We always need to have them. So one of the things that happens, and I'm not going to spend any time on this either, is how the receptors are regulated. So, and this is all theoretical. Nothing has actually been proven about this, and that's the big problem with addictions treatment, is that we work off of theories that most people believe. And then somebody comes along and changes the theory. So our theories about addiction have changed drastically over the last 25 years. But they're still theories. Nothing has been proven. So one of the beliefs is, so imagine that a drug of abuse is used and all this dopamine comes flooding out and hitting the receptors and causing euphoria. And the brain is saying, there's something wrong with this here. this is having a horrible effect on the body. So what the brain starts doing is killing the receptors. So for instance, if on a neuron we have 100 receptors and all this dopamine comes out. So normally, let's say there's 100 receptors on the neuron, and in order for you to feel happy, 25 of them have to be stimulated. All right, and obviously the more you get stimulated, the happier you are. All right, now somebody uses drugs, all 100 get stimulated right away, so all this dopamine comes out, and 100, and it's constantly hitting those 100 receptors. The brain says there's something wrong here, there's too much stimulation. So what it does is it begins killing off the receptors. So it says there's 100 being stimulated. If I kill the receptors, then I'm decreasing the level of stimulation. That's basically what happens in tolerance. So there's less and less receptors over time, and then that's also what happens. So the person stops using drugs, and they want to experience happiness. They can't, because they not only don't they have any more dopamine, but they have much fewer receptors to stimulate. So they're incapable of feeling anything but depression. And we see that in this population. Now, here's the problem. In somebody that has stopped using drugs, it takes a minimum of 4 to 6 weeks for the brain to remanufacture those receptors. So we have patients, and so that was the whole basis. Nobody really understood what. But when we talked about 28-day programs initially, the Minnesota model 28-day programs, they said that if people went through 28-day programs, they have a greater chance of staying in recovery, staying sober. And nobody really knew why that was, but now we know. At the end of that 28 days is when those receptors have rebuilt themselves and the person can begin experiencing regular feelings and not just depression. And so they had a better chance. Today, there are, for instance, on the West Coast, the only people that get inpatient treatment for addictions are those that pay cash. Insurance won't pay. And on the East Coast, we're finding that that's increasing more and more, that insurance companies aren't paying for any length of stay for inpatient treatment. So what we find is patients come into detox, and so we get them off the drugs, but their brains haven't recalibrated, so they leave after detox, they're still feeling depressed. We do not have an antidepressant that works as well as cocaine. So how long is somebody going to have that feeling of severe depression and know, well, if I use a line of coke, I'm going to feel good? And that's what happens, because the brain hasn't recalibrated itself yet. So that's one of the big problems that we have with the populations that we work with. It takes a while for the brain to remanufacture those particular receptors. Now, another important area are the enzymes in the brain, because they're the ones that destroy the neurotransmitters. So as I said, we have all this dopamine flooding the nucleus accumbens, and if the person isn't using cocaine, let's say that they're using any other drug of abuse, what ends up happening, remember, after the dopamine falls off the receptor, it gets sucked back into the cell to be reused. But there's so much dopamine that it clogs up that transporter that's sucking them up. So now we still have all this dopamine here that wants to get back into the cell, but it can't. You know, it's kind of like 100 people going into the subway, there's only one turnstile. All the others are broken. So we're going to have this backup. Well, in the brain, these policemen call enzymes, a special name, COMT, I'm not going to get into the names, but that comes along and it destroys all of the dopamine that's just hanging around. Because the COMT is saying, you shouldn't be out here, it's past your curfew. You need to get back into that cell. You're not getting back in there, because there's only one turn still going to go through, so it's killing them off. So now the body's losing all of that dopamine. And another way that the enzymes are destroying the dopamine too. Okay. Nothing really that I don't really want to get into the subtyping of the receptors. We're not that good with our drugs at figuring out which receptors we want to hit. The brain's very, very good at doing that. So for instance, when serotonin 1A is stimulated, it takes away depression and anxiety. Now when 2A is not up here, if 2A is stimulated, it causes severe anxiety. So when we give somebody any medication that increases serotonin, we want it to hit the 1A to take away depression and anxiety, but it hits all the serotonin receptors. So it causes anxiety. Right, so all the SSRIs hit all the receptors, and initially they cause anxiety. The same thing happens with drugs. Okay, so every chemical in the body stimulates receptors. That's what they do. Plain and simple, a chemical, we call them neurotransmitters, finds a receptor and stimulates it. We can't figure out how to balance that. So for instance, when we have an allergic reaction to something, normally, that makes us sneeze. Let's just say something gets into our airways and we begin sneezing. The body is able to balance the neurotransmitters so that the allergen can be collected and thrown out real fast. We can't do that with the drugs that we give patients. We have to give antagonists. So we have to give antihistamines to work on runny nose and all that. There are some people that if something stimulates and causes a runny nose, that after a short period of time it goes away. The body has figured out how to stimulate a whole bunch of different receptors to make that stop. You know, we don't know how to do that. We don't know about those combinations. So what we do when we go to give somebody a drug is that we give them an antagonist so that that receptor can't be hit. And so we're talking about people that OD. So all the drugs of abuse are agonists. They stimulate receptors. Now when somebody's using too much and they OD, we don't know what agonists we can give them to make them better. So what we have to give them is an antagonist, something that covers the receptor so that that drug doesn't hit it anymore. The body doesn't make any antagonists. The body doesn't make antihistamines. We have to manufacture them externally and give them to the patient. So the agonist system is something that occurs in nature, but in pharmacology, we have a whole slew of different things that we give. So everything that happens in the brain is an agonist. All the drugs of abuse are agonists, but we end up, when we have problems, we end up having to manufacture different mechanisms to work on the brain. It's not that you need to know this, not that important at this point, but you're going to see when we're talking about treatment of overdose and even treatment in maintenance that we want to use antagonists is one area, and in substitution therapy, obviously, we use agonist therapy. So for instance, somebody is an opiate addict, the opiates are agonists. What we want to do in harm reduction is substitute what they're using for a safer drug, so we give methadone. So methadone is an agonist just like the opiates are. But other people want to use something like naltrexone, Vivitrol, they're antagonists. Camprol's an antagonist. So the way they work, and when we get to that, you're going to see, all we're doing is giving a drug that blocks the receptor. So even if somebody's using, they can't get high from that. Okay, so the agonists stimulate the receptors. You don't have to worry about what it does after it does that, but they stimulate the receptors. The antagonists block the receptors. That's what they do. So whenever I explain antagonists, I say all you need to think about are those plastic covers that are baby-proof in your electrical circuits, switches, plugs in the wall so kids don't put their fingers in, those little plastic things. That's exactly what an agonist does. It covers the receptor. So that even though, so if we give somebody naltrexone, it's covering all of the opiate receptors. So if somebody begins using heroin again or OxyContin, the OxyContin and heroin's in their system, but it's not hitting any of the receptors, so it's not doing anything. So it's as if those receptors didn't exist. Remember, think of the catnip story. So it creates a situation like with catnip that those with when the brain is full of antagonists, the receptors aren't there for the drug, so it has no effect. So people that really want to use that are on antagonists, what do they end up doing? Stopping the antagonist so that they can get high again. That's what they do. Okay. Inverse agonists, I don't spend any time with. Partial agonists, that's more along the line in psych and talking about how that works. In addiction, we really don't use that much, so I'm not going to pay any attention to that. Now, the other thing that we're most aware of today is co-occurring disorders. We used to, if you worked in addiction, I remember when I first started, I worked in general psych. And basically the rule was, in my facility, somebody came in with a psychiatric disorder, you worked with them. But if they had a substance use disorder, you had to send them to a drug and alcohol facility to take care of that, and then they could come back and we could work with them. And then the reverse was true. That if somebody went to a drug and alcohol facility with a drug or alcohol problem, but they also had a psychiatric problem, they were sent away and said, you need to get that psych problem taken care of before we work with drug and alcohol. Today, we're supposed to be treating them integratively. So the feds call it the no wrong door doctrine. The patient should be able to walk into somebody that has a co-occurring substance use disorder and psychiatric disorder should feel equally comfortable in a drug and alcohol facility or a psychiatric facility. Both facilities should be able to treat equally both the substance use and the psychiatric disorders. So in the past, we ignored, depending on which side of the fence we lived on, we ignored the other disorder completely. Today, we're supposed to integrate treatment, we're supposed to acknowledge it. So we're seeing, we're becoming more aware of this population and hopefully treating them. Now, we're still not doing a heck of a good job. You know, we're really not doing a heck of a good job. I work in a drug and alcohol facility, and I'm constantly on my counselors' backs because they're doing a good job in treating drug and alcohol, but they're not doing a good job in working with the psychiatric problems. So that continues, and I don't understand what the problem is there. Okay, so basically, here's the current theory for addictions. And also for psychiatric disorders. We basically have to have two conditions. We have to have an internal stressor and an external stressor. So the internal stressor is what we call genetic vulnerability. We have to have the gene mutation in order to have an addiction or a psychiatric disorder. We have to have that in our genes. If we don't have it, we'll never get it. We also have to have an external life event stressor that turns the gene on. So the gene for psychiatric disorders And for addictions, if it is mutated, it's in the off position at birth. It's in the off position. Something has to happen on the outside to turn it on. Now, we've known that for a long time with depression. So with depression, if you're talking to a patient that suffers from depression, they're always very, very good at being able to tell you what happened when you first experienced the first time you felt this depressed. And they'll be able to tell you about an external event that occurred that turned it on. Theoretically, we can do that with every disorder. We can even do it with addictions. So, for instance, self-disclosure, my family on both sides, addicts throughout. Right? I have 5 siblings, 4 of them are in an active addiction. I'm not. Do I have the gene? I have to. It's on both sides of the family. I have to have it. Why hasn't it turned on? I haven't experienced what I consider a trauma necessary enough to turn it on. Right? So my mother, for instance, she's a 3 to 4 pack a day cigarette smoker. Right? She's like 88 years old. She still smokes. And Camels, no filters. Heavy smoker. She has the gene. How come she doesn't have any other addictions? She hasn't experienced anything that would turn on anything else at this particular point in time.
Yeah, but by the same token, let's say you say you have the gene because somebody in your family, directly their father or mother has an alcohol or an addiction problem, to your knowledge, correct? So you would have that gene automatically, you say?
If both have it, yeah. If both
Okay.
have the gene, I have it.
All right, so by the same token, I've seen people who have that and have experienced life stressors, big time stuff such as divorce or really bad stuff happening in their life, and they still didn't go into drugs or alcohol.
It didn't reach the threshold of the stressor for that individual person. See, everybody has a different threshold for experiencing stressors. So apparently my threshold is fairly high. So yeah, we all have problems going through life, divorce, injury, all kinds of things. Can't keep up with the bills, all that kind of stuff. But for an individual person, that may not have reached the level of stressors, to turn on the gene.
So that they will be a pretty strong person.
Right. But that's not something that, when you say strong, we're talking physiologically and psychologically, not something that we can change. We can't change that threshold. It's what happens. So that's an important consideration. We've always known, for instance, for 50 years now, we've known that diabetes, every single human being has the gene for diabetes. And the gene for diabetes, it's on the simple way that they explain it, it's on a time clock. And every individual is set differently. So some people, we call them the type 1s, have juvenile diabetes. It's turned on in childhood. Others develop it later in life. But they say everybody, every single human being has the gene for diabetes, but the time clock is set to go off at a different time. So for instance, for me, maybe my time clock is set for age 95. But if I die at 88, I don't get it. Right? If I live to 96, I'll get it when I'm 95. So we all have that. So everybody that has diabetes, we know that the time clock went off. For those of us that don't have it, it's in the system, the time clock the alarm hasn't gone off yet. And for every individual, it's different. It's a different age for every individual. Nobody understands how that works, but they now understand that whole concept for that. So we think that there may also be a similar situation with psychiatric disorders and addiction. how that may work too. As I said, it's very, very complicated. We don't have all the answers. We try to make it simple. But, you know, when people say, well, how come everybody in this person's family has an addiction, that person doesn't? Or how come in this large family, only one person has an addiction and nobody else does? You know, don't know the answers to that. Because everything today is still theoretical. And we follow the theory that most people believe. That's basically how that works. So we say that people don't inherit a mental illness or substance use disorder. They inherit vulnerability to it. So it's there, ready to turn on, but don't know how that's going to work. Don't understand it. It's different in different families. So for instance, one of the things we now know, in the old days, when somebody went through treatment for depression, the question that we always get is family history. Do you have any family that suffered from depression or anxiety or anything else? And suppose the patient says, yeah, my mother's sister, my aunt, has depression. And then the next question we would ask is she on any medication? And the patient will say, yeah, I believe she's on Zoloft. Well, the rule was, and then we ask, is it working? And the answer is yes, it's working. The rule used to be, well, if the aunt was on Zoloft and it worked, give the patient Zoloft. That used to be the standard, the practice guideline. Today, we now know that even in families, different genes cause depression. So in Aunt Peg, who has depression, they've identified a certain gene or several genes. In the patient in front of us, they may have completely different genes that are mutated, causing the depression. So now we know the Zoloft won't work necessarily in this particular patient, because depression even in families is caused by different gene mutations. So it's the same thing with addiction. So we have what's referred to as the two-hit hypothesis. In the scientific terms, we call it the stress diathesis model, but it's easy to remember the two-hit hypothesis. And as I said, I already explained it, two things have to happen. There has to be an internal genetic vulnerability, and there has to be some type of second hit in the environment to turn it on. That is the current theory for addiction and psychiatric disorder that most people believe. Okay, so now I'm going to talk about tolerance, intoxication, withdrawal, and drugs and abuse. So here's the DSM-5, their definition of substance use disorder: a problematic pattern of substance use leading to clinically significant impairment or distress as manifested by at least 2 of 11 criteria during the same 12-month period, right from the DSM-5. Now, they made a change. DSM-4 said, they started out by saying a maladaptive pattern of substance use. So if you have a DSM-4 and you look at what it defines as substance use disorder, or they call it dependence in DSM-4, it started out by saying a maladaptive pattern of substance use. And everybody said, well, what does maladaptive mean exactly? Because one of the things that the DSM does, and they always did, is they give us definitions, but they don't tell us what the terms mean that they use. So it said a maladaptive pattern of substance use, and everybody wrote back and said, well, what does that mean exactly? And nobody could come up with a standard answer. So when DSM-5 came out, they took out the word maladaptive, and they put in problematic pattern of substance use. Well, now we're asking the same question. What exactly does problematic mean? Who determines when it becomes a problem? And so the answer is that's left up to the individual clinician to make that determination based on the presentation. The other thing is, okay, so then they said leading to clinically significant impairment. But what exactly does that mean? What is clinically significant impairment or distress mean? There is no, you won't find any place in the literature definitions for that. They basically say it's up to the person doing the evaluation to make that determination. impairing or distressing as a result of their use. All right? So there's a lot of open areas for us to work with that definition. But then they give us the criteria. So the essential features of diagnosis is a cluster of cognitive behavior physiological symptoms indicating that the individual continues using the substance despite significant substance-related problems. Okay, so that's the first part that we always have to keep in mind. Are they having problems in their life and yet caused by the substance and yet they continue to use? So that, based on history, helps us answer that question. We know that there's a change in brain circuits that persists beyond detoxification, particularly in individuals with severe disorders. So basically what we have to understand is that with time, drugs of abuse change the brain. More times than not, it's reversible. Sometimes it's not reversible. So the criteria are broken down into certain sections. So we have impaired control, social impairment, risky use, and then what they refer to as the pharmacological criteria, which are the last two. So under impaired control, we have criteria number one. The substance is often taken in larger amounts over longer periods than was intended. All right, so now what the DSM is telling us is we have to go through this list and see what applies. Now, the DSM-5 says the person only has to meet 2 out of the 11 to get a diagnosis of substance use disorder. Only has to meet 2. Everybody that walks into my place, we say to them, okay, or they'll tell us, you know, I had a stressful day at work, and so the older patients will say, had a stressful day at work, so the guys decided we're going to go out to a club and have a couple drinks, to the corner bar, and that would be it, and they ended up closing the place. They only intended to go in to have 1 or 2. You know, I hear this all the time with parents at their child's wedding. Well, I was just going to have the champagne toast, nothing else. And I ended up becoming completely intoxicated. So they meet that criteria quite easily. The younger folks will say, I went out with my friends to a club, and I knew they were doing cocaine in the bathroom, so I figured just to be sociable, I'd go in and do 1 line, and I ended up using the whole brand. You know, hear that constantly. So they would meet criteria number 1. You know, did they intend to use that much or for that long? The second one is a persistent desire or unsuccessful effort to cut down and control their use. Practically everybody that comes into my place, we ask them, have you ever tried to stop? Practically all of them say, yes, I have. I just can't. Just can't stop. Number 3, a great deal of time is spent in activities necessary to maintain use and recover from the effects. Now, DSM-4, one of the major changes between DSM-4 and DSM-5 is this criterion. This used to be in DSM-4 criterion number 5. And this is the criterion that we use to determine severity of addiction. This particular one alone. How much time in their life is spent finding the drug, using the drug, recovering from the drug, at the expense of doing everything else. And the more time that was spent in doing those activities, the more severe the addiction was, plain and simple. So that's how DSM-4 had us determine severity. DSM-5 has changed that radically. DSM-5 says severity of addiction is based on the number of criteria the patient meets. So it's no longer this particular one. All right, it's how many criteria that they meet. So somebody that meets 2 criteria, no matter what 2, is classified as mild addiction. If somebody meets 7, it's considered severe. All right, so that's how they're doing it now. A lot of us disagree with that, because suppose somebody only meets 1 and 3, but in number 3, they spend 20 hours a day finding, using, and recovering from the drug. Can't do anything else. Maybe they get 4 hours sleep a night. They can't work, they can't take care of anything, but that's all that they do. Under DSM-5 criteria, that would be mild. So most of us disagree with that, with that way of doing it. Number 4, craving, and this is new in DSM-5. This was not in DSM-4. Craving or a strong desire or urge to use. So if somebody's experiencing that, we now count that. And again, most of our patients will experience that. Bypass that. Social impairment now is the next major area. Recurrent use resulting in the failure to fulfill major role obligations at work, school, or home. So basically, they're not able to do the other things that they would normally have to do to live a productive life. People will always be able to tell they have frequent call-outs, or they're late, or for nurses, impaired nurses, they disappear for a period of time. At work is something that we'll hear. Continued use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the drugs. So people that can't focus at work, their productivity is down as a result of their drug use, that type of thing. We get a lot of patients that meet that one. Important social, occupational, or recreational activities are given up or reduced because of use. This used to be criterion number 6, which is the opposite side of the same coin as what was number 5. So number 5 says, over a period of time, you're using, finding, and recovering more and more time, and therefore, number 7, you're spending less and less time doing everything else. So they kind of go hand in hand, right? As you're spending more time using, finding, and recovering from the drug, you're doing less and less of everything else in your life. So pretty much, they go hand in hand. So you already have the 2 right there that they'll meet. And then risky use, recurrent use in situations in which it is physically hazardous. So this is an important one, and it really takes skill in getting information. Just a few months ago, I saw a patient come in. It was an elderly gentleman, and very much in denial, as a lot of our patients are, I'm sure you realize. And he said, well, yeah, I do drink, but I generally only have maybe a couple sips a day. Well, we know that our patients generally underreport, but he says I only take a couple sips a day, usually in the morning and the afternoon. So my next question was, well, do you work? He says, yeah, I work. I said, well, what do you do? He says, I'm a school bus driver. Well, so there we go. So now he would meet, right? So if he sat home and only took a few sips a day, in the morning when he got up, and, where is the impairment? We would say, no, they wouldn't meet that. So we look at, are they driving kids? Are they working with heavy construction equipment? All that kinds of things, which creates risk. Then they would meet that criteria. And then number 9, continue use. This is one that everybody meets. Basically, what number 9 says, I know it's bad for me, but I do it anyway. Everybody does that. Everybody that smokes says that. I know what they say. I know that they say it's related to lung cancer, but I smoke anyway. So everybody meets that one right there. And then the 2 pharmacological criteria are tolerance and withdrawal. So tolerance, by definition, means it takes more and more of the drug to get the same effect. All right. And then withdrawal, all of the drug categories. Once the drug has stopped, with the exception of one category, will exhibit a withdrawal syndrome, which we will also talk about. Pseudo-addiction is another one. I'd like to talk to the med-surg nurses about pseudo-addiction. This is symptoms of tolerance and withdrawal occurring during appropriate medical treatment with prescribed medications. And also symptoms related to under medication. So the two different areas. So let's say, for instance, we're dealing with somebody that is not addicted to anything, and they're involved in a car accident, and they're in the hospital. I remember when I was involved in a car accident 30 years ago, and I was hospitalized with broken bones and all that, and And I happen to be what's referred to as a rapid metabolizer. Anything that I put in my body, my liver destroys practically immediately. So if I get a headache, I can't take 2 aspirin, I gotta take 6, just to get rid of the headache because my liver breaks it down really, really fast. So I'm in the hospital, I'm a big guy, I have these broken bones, and the doctor orders for pain one Darvocet. Back then it was Darvocet, right? 1 Darvocet for pain in Q6. Well, that's like giving me a chiclet, right? So I said, I need more. And so what was the response to the good nurses? Oh, we don't want to get you addicted. Or maybe you already are addicted, and we're just helping that along. So that's when we think, when we're not properly medicating the patients for pain, and they're asking for more for their pain, it looks like they may be an addict or addicted. They're really not, right? So that's what we have to be careful of. We have to, and I tell folks that work on surgical floors, you always have to determine whether or not we're actually properly medicating the patients for pain, whether they're in an addiction or not. Even people in an addiction have the right to be pain-free. They just need a lot more. So here's another example. I just had this at one of the hospitals I went to talk to the nurses about. They had a patient which was known addict, heroin addict. He was actually OxyContin. And he was using 400 milligrams of OxyContin a day to keep his habit up. And he had been doing that for quite a long time. Right? He gets in a car accident. He breaks both his legs, his arms, he has some fractured ribs. So he's on the unit, and they order him 2 Percocets Q4. Once again, he's used to having 400 milligrams of OxyContin a day. In Percocets, there's 5 milligrams in each one of OxyContin. So over the period of the day, if it's Q4, so 6 times 10, he's getting a total in 24 hours of 60 milligrams of OxyContin when he uses 400 milligrams a day. Do you think that 60 is even going to touch pain? No, it is not. Additionally, he's going through the pain of withdrawal. So it's not only the pain of trauma, but it's also the pain of withdrawal. And I'll say to the docs, you really got to up the dose, but they're all afraid to do that, with these patients. So what ends up happening, they end up suffering terribly. That's the other thing. Now, the other important thing to remember about pseudo-addiction is, and this is why the DSM-4, we used to have the word addiction in the earlier,
What would you have recommended?
I would have said do spinal. I would have said do a spinal, anesthetize the body as best you can if you're afraid of that. Use lidocaine patches. They generally don't work with severe trauma. I try to get them to up the dose. What I tell them is, go ahead and up the dose, just monitor the respirations. That's all you got to do. That's what we worry about with opiates. When people OD with opiates, it's because they go into respiratory failure. That's how they die. It's not liver toxicity. With Percocets it is because it contains Tylenol, but with OxyContin, it's respiratory failure. So I say, begin to aggressively up the dose of the oxys, monitor the respirations. You're going to see if somebody's using 400 milligrams, they're tolerant to that. You're not going to see a change in respirations. They're still afraid. Every once in a while, I'll get somebody that says, okay, well, we'll do that. I'll get the nurses on board to monitor the patient. And, they're surprised when they're giving them several hundred milligrams of oxys at a time, and it's not even, it's not touching the respirations, but it's just getting them to feel comfortable doing that. Working with that population becomes problematic. So then I just say, do spinals, do spinal anesthesia with them to get rid of the pain. That way you don't have to worry about anything. And sometimes that'll work, sometimes they'll say, no, we're not going to do that either. Now the other thing is, okay, so they used to have the term addiction, and then the DSM decided, well, that's too pejorative, that's a bad word, let's change it to dependence. and they went to dependence, and everybody was real happy with that, but that created a lot of problems. Remember I said we have our own terminology in our profession, and that word has different meanings to different people. So when we use dependence, DSM-3R and DSM-4, we were referring to chemical dependence, not physiologic dependence. So here's the rule for dependence, which is not pathology. So any controlled substance that a person has been prescribed, if they take it daily for a minimum of a month and they stop, they'll go into withdrawal. Most people will say, if I'm going into withdrawal, I must be addicted. But they're not. That's a natural occurrence. They go into withdrawal because they stopped taking the medication. This is the other big problem that I tell the docs in the ER. Okay, somebody comes in with a broken arm or a broken ankle or something like that, and you give them a script for Percocet for a month. And they say, this is probably more than you're going to need, but take it so you're pain-free. And they'll take it for the month, and then they have no more, they stop, they go into withdrawal. Now the family thinks they've become an addict. And so that has created more problems than not with people that are not addicted to medication, but really need controlled substances. Patients that have severe anxiety that needs Xanax, or Clonopin or something like that, and if for some reason they don't get their prescription refilled and they stop taking it, they go into withdrawal. So now they believe they're becoming addicted, they stop taking it, and they'd rather suffer than be called an addict, when those people really do need that medication. Same thing with chronic pain people, terminal cancer patients. You know, they'll say, no, I don't want to be addicted. You know, terminal cancer, I just want to strangle people sometimes. They're in horrible pain, especially the bone cancer patients. Horrible pain. And they're probably not going to live more than a couple months. And they're in horrible pain. And I'll talk to them and I'll say, you know what, we really need to give you medication to take care of this pain. I don't want my last days to be as an addict. Well, first of all, even if that was true, so what? But it's not, you know. So I always have the general population and people that work in primary care talking about pseudo-addiction and how it affects our patients. And I tell nurses, you know, somebody on the floor, even if you know they're an addict and they're in horrible pain, don't worry about anything. You know, don't. I remember when I worked the floors, and I'm going back, you know, a long time, back in the 70s, you know, we were really self-righteous. You know, that's an addict, I'm going to give them a placebo for their pain. That's what we did, you know, back then. We filled the syringe up with saline and say it was morphine. You know, and we felt that we were doing the right things. Today, that's considered abuse to do that. But back then, it's what we did. We didn't understand addiction back then. But today, that's pretty much unethical to give placebos to patients, no matter what. It's not our job to make that judgment, and that's what happens.
Just to kind of clarify, so this dependence, so I know anyone who is on a controlled substance for a minimum month, and if you stop, you're going to experience a withdrawal. So it's kind of like it's a crossroads. So you've got the folks who will say, okay, I never ever want to go on those again because of that experience, and then you have the other folks who would say, oh my gosh, I need more. Maybe now I need to start using heroin because I don't ever want to feel like that. And do you think like the difference there is that genetic predisposition that was, you know, that gene that was kind of like turned on, like at that crux, like the people who were like, oh my gosh, I never want to go there again, or oh my god, now my doctor won't give me any more whatever, I need to go buy, you know, 10 bags of heroin in the street.
Right. And it could be. That could be correct. More times than not, I tend to believe that it's not. I think our big problem in the United States is not the prescribed medications. It's the management of the patient. You know, patients that are on controlled substances need to be weaned. They need to be tapered at the end, not stop cold turkey. That's number one. Number two, patients that are on any type of controlled substance need to be intensely monitored. We don't do that either. Somebody that goes in and gets a prescription for Xanax will get 6 refills. I'll see you in 6 months. Well, you know, they begin doctor hopping and find 6 doctors that will do the same thing. And here, you know, we'll get patients that come in that are taking 50 milligrams of Xanax a day. That would kill an elephant, you know, but they've grown tolerant to it. And the way that they get it is they either buy it off the street or they doctor shop and get a whole bunch of doctors to write them scripts. And a lot of the benzos now are generic, and so they're not that expensive, and so they can maintain that habit. Nobody's really monitoring what they're doing.
The little thing that's
I
like,
stop now, that's being curtailed.
Yes,
That's
it is.
to prevent that from happening.
Right, but there's still a bunch of states that are still not following that. You know, that it's not law. That's the problem. So, it's voluntary for some states. Other states it's mandatory.
In New York.
And then some states don't have it at all.
Okay.
There's still a few, but a lot of them are voluntary.
so you don't think it has anything to do with that genetic predisposition, why, you know, the person would go down that road and go doctor shopping? Versus, you know, I guess I'm.
Well, right, but we have to apply the criteria.
Okay.
You know, do we, as a result of this, have impairment, or are we really under-medicating them? You know, I have seen patients that both that have an addiction and don't have an addiction, that have severe anxiety, and their doctor will refuse to order them a benzo for that, to help with that in the short run. They'll say, you know what, I'll give you Prozac. Well, Prozac's going to take 6 weeks. People with severe anxiety can't wait 6 weeks. So they're going to do what they need to do. So we always have to be able to tease out, are they really under-medicated, or are we really developing an addiction here? What's really going on? And we can only do that by following them, by monitoring them, by understanding where the level of impairment or distress is really coming from, and applying the criteria. That's what we have to do with that population. Okay, this is just this is one of those scientific slides in which I really go into how tolerance actually works. You know, how the person needs more and more of the drug to get the same feeling. So I'm really not going to spend any time on that, but I just do. Okay, so intoxication syndrome. This is what the DSM-5 says. Intoxication syndrome is a clinically significant problematic behavioral or psychological change. For instance, inappropriate sexual or aggressive behaviors, mood lability, impaired judgment that developed during or shortly after use of the substance. So that just makes a lot of sense, what it is. But every single class of drug, every category, has its own symptoms of intoxication. And so, with the slides that follow, I give you the general effects, the effects of intoxication. But what we're most interested in is the effects of overdose. That's what we worry about for those of us that work in addiction. Always a big problem. So when anybody ODs on any of the opiates, it's usually because all the opiates, in addition to going to the nucleus accumbens, the ventral tegmental area, and releasing dopamine, they all go to the respiratory center and they turn it off. So when people OD on an opiate and die, they die from respiratory failure. That's generally what happens there. So we are always monitoring respirations of patients that have been using opiates. And we don't know, for instance, so we'll have people, and when I talk about alcohol, I'll tell you a funny story, but we have people that walk in that are using 400 milligrams of OxyContin a day, and they're feeling normal. But we could have somebody that ODs on 75 milligrams. It depends on tolerance. So when anybody comes in, we never really know their level of tolerance. Okay? So we have to monitor them no matter how much they're taking. I go crazy when the nurse says to me, well, you know, he's only using 50 milligrams of OxyContin a day. Why should we have to worry about that? But we don't know what his level of tolerance is. right? And we don't know whether he's underreporting. That's the other big thing. Are they telling the truth? Okay? For the depressants, which includes the barbiturates, the benzodiazepines, and alcohol, the effects of overdose, once again, those drugs and alcohol also hit the respiratory center, and if there's going to be overdose, it's going to be respiratory failure. All right? So that's important. The blood alcohol levels, everybody should be familiar with the blood alcohol level charts that are out there. And it'll give you the blood alcohol level and then tell you correspondingly what's going on in your body. And usually when the chart says if the blood alcohol level is above 0.25, we're usually looking at stupor or coma, and then going higher, death. And state police use those things, and every state has their own level for DUI. Pennsylvania, which is where I'm from, it's 0.08. If you're above 0.08, you're DUI. So those charts are not clinical charts, they're forensic charts. They don't take into consideration tolerance at all. So 0.08 means absolutely nothing in addictions. It only has meaning to police, to forensics, not to us. And the story I want to tell is we had a while back, it was, I guess it's already past a year, it was a February night, and as usual in most drug and alcohol 24-hour centers, everybody goes home except nursing. They're the only ones that are still there 24/7. And so all the doors get locked, and nursing is still in operation. Everybody else is gone. And so if the patient comes after hours, it's nursing that has to go up and unlock the door and bring the patient back and do the assessment and all that kind of stuff. So this one night, it was a cold, snowy, icy night. It was like at 1 o'clock in the morning. And the doorbell rings, and the nurse goes down and unlocks the door, and it's this little old lady. She happened to be like 65 years old. And so they let her in. She says, I have a problem, I need to be admitted. My family's been after me, and I decided, they come in at the craziest times. So it's like 2 o'clock in the morning, a cold February night, it's icy out. She drove herself to our place. So the nurse lets her in, and is walking her back to the detox unit. And in the note, it says that the woman was alert, she was able to walk fine. The only thing that they thought was a little odd is that she was singing along the route. But then they thought, well, she's 65 years old, she was singing. That's okay. But the nurse documented it anyway. So they get her back to the nurse's station, sit her down, and they do a breathalyzer. And her breathalyzer was 0.475. Above 0.25 is coma. She's 0.475, and she's walking fine. She drove herself in the middle of the night to our place. That's how tolerance works. Unbelievable what tolerance can do. So we don't know when we do a breathalyzer what effect tolerance has on that. Do we worry that they could become comatose? Yeah, all the time. We really have to monitor them. So that value, what we're most interested in is watching it come down. But we don't really know what the value means to that person. And so that's the importance of monitoring them visually, right? Not just, so we've had patients that came in that were like, we had a gentleman that came in that had a BAL of, it was less than 0.2, it was like 0.15, I think. And in my place, that's low. So the nurses just normally put him to bed. And guess what? We found him dead the next morning. Right? So I tell them we can't give meaning to that value because we don't know how that individual is affected by it. What we're more interested in is to assure that it's coming down over time. Yeah.
I find it challenging when you're teaching your med-surg nurses or your nurses in acute when they see these high shock me numbers, and you're talking about the lady walking in with a 0.4, and, you know, we've seen that they, when does withdrawal start and risk for seizure occur, that they're waiting for that number to go too low,
Right.
and they're, you know,
And
they're
another very important
that is
consideration.
really hard to
Right.
teach
Right,
them that.
I'll always test new nurses on that. I'll say, for instance, that's an excellent point. I'll say, so a patient comes in and their BAL is 0.27, and then an hour later, it's 0.12. Are they intoxicated or in withdrawal? Well, we have to see symptoms.
You can see the symptoms,
So-
right.
So most nurses will say 0.12, they're intoxicated. Now, what most nurses are familiar with is the behavioral manifestations of withdrawal. What behaviorally does withdrawal look like? We never ever teach in school or even on the job what the biologic definition of withdrawal is. The biologic definition of withdrawal is the drug falling off the receptor and leaving the body, being destroyed. That's the biologic definition of withdrawal. So when the BAL goes from 0.27 to 0.14, the one thing I can tell you is that much alcohol has left the body. At least left the bloodstream, the respiratory center, right? So the person is in withdrawal. So if we see symptoms of withdrawal, even at that level, we have to medicate. Again, people get squeamish about that. Well, wait a minute, we have to wait until it gets down to 0 before. No, you have to understand what biologic withdrawal is. You know, it's the same thing with opiates, with benzos, with everything. As the drug falls off the receptors and leaves the body, that's the biologic definition of withdrawal. And we need to understand that. They are in withdrawal when their levels drop. So that's another consideration. That's a very, very good question there, or comment. So the stimulants, we worry about, so just like heroin, just like the opiates and the depressants also target the respiratory centers, all the stimulants really work on two systems, the cardiac center and the hypothalamus. So about 5% of overdose deaths from the stimulant is because the hypothalamus was overly sensitive. The hypothalamus, among other things, controls body temperature. And what the stimulants do is they throw off that mechanism. So the body temperature begins rising. Generally, people that are intoxicated on the psychostimulants come in with fever. A good number of them do. Now, the ones that die from that, their fevers will go up to 106, 108. So the brain just fries is what happens and they die. That's probably about 5% of the deaths from that population. But the other target organ for all the psychostimulants is the heart. So one of the things, and the way I relate that is, you know how anabolic steroids work on skeletal muscles and build up the size of the muscle. They bulk up the muscles. That's what anabolic steroids do. The psychostimulants do the exact same thing, but to heart muscle. So they hit the heart and make all of the cardiac cells bulk up. So the heart becomes enlarged. So people that have been using the psychostimulants over a period of time will have enlarged hearts. When you listen to their hearts, you see a split, S1, S2. You can hear the split. You can tell that it's enlarged just from that. Now, when we think physiologically, what happens when the heart enlarges? When the heart enlarges, it's bulkier, it needs more oxygen. How does the heart itself get more oxygen? It has to beat faster. So these folks will also come in, not only with elevated body temperature, but also pulse. Now, if they've used a lot, sometimes the pulse goes up to like 240, 250, and the heart just can't sustain that. after a period of time, you go into heart failure, the heart just stops. So the vast majority of folks that OD on the psychostimulants, OD from cardiac failure. That's usually what kills those folks on that. Cannabis, the effects of overdose, dissociation, depersonalization, poor concentration, sometimes psychosis, anxiety, paranoia, when we see that. With the hallucinogens, effects of overdose are an intense trip experience, psychosis, death, not necessarily from the chemical reactions of these drugs, but because of the belief systems that they get. So we have patients that believe they can fly, that they can walk in front of traffic and trolley cars aren't going to hurt them. You know, so it's because of their belief system that gets changes. Now with MDMA or ecstasy, we get malignant hypothermia. That's ecstasy, MDMA, and then they die from that. Is usually the cause of death, because that targets the hypothalamus pretty much. And then inhalants. This is a relatively new one that we've added within the last 5 or 6 years that we've become very much aware of. This is usually in the 7 to 11-year-old. We see this. We in addictions call this the hidden addiction, because no parent wants to believe that their angel could possibly be huffing. Nobody wants to believe that. So it's very, very hard when we go and talk in elementary schools about inhalants. The parents always walk out confused saying, why are you telling us this? Our child doesn't have this problem. But what I tell them is, okay, what I want you to look at are the behaviors that your child is engaged in. So, do they come home either lethargic or restless? Don't generally see slurred speech. Do they come home complaining of headaches a lot or nausea? Confusion, so they can't concentrate. Do you see that? They say yes. I say, well, what do you think's going on? And they have a whole litany of excuses. Too much homework. Bullies in school. Mean teachers. These are all the reasons that my angel is having these problems. You know, they don't want to look at this. So I tell them, I give them some statistics, some of the demographics that we know. We know that most kids, if they're going to use inhalants, do it from the point that they leave school to the point that they reach home. Statistically, that's where they use it. And there's another funny statistic about this. The kids that huff, that breathe in inhalants, wear hoodies. Because what they do is they take the can of aerosol spray, whatever it is that you can find in any house, hold the can upside down, pull the hoodie over their head and spray, and then that keeps the environment of the drug right in there so that they get a higher high. Now, it doesn't mean that every kid that wears a hoodie is huffing, but the majority of huffers wear hoodies. So I asked them, you know, take the symptoms. Does the kid wear it? Because they teach them this, to wear the hoodie and pull it down over their head and then just spray the can. And also look around the house. Are you noticing that cans of deodorant are missing? Or fragrances? Anything that has the chemical propellants in them, do you find that they're missing from under the sink or wherever you keep them, you know? So I say look for those types of things, and that'll clue you in. The good news is that 95%, probably higher, of the kids that huff grow out of it. And that's the end. They don't do that. It's rare that we find an adult that continues huffing. And it's never been proven that huffers are gateway drugs gateways to other drugs too. That's never been proven. Although a lot of folks that we see will say that as children they did huff, but they huffed the drugs, but there hasn't been any proof that it's a gateway. For opiates, cocaine, and other drugs, complications are often related to the route of administration. So that is what you always have to be very much aware of. How are they using the drug? Are they injecting it? Are they snorting it? Are they crushing it and swallowing it? What are they doing? So in injection drug use, we worry about skin and soft tissue infections, cellulitis. We should be, you generally, a lot of times get a false positive screening for syphilis. That's why when an RPR is done, they always need to confirm it with an FTA-ABS just to make sure, because a lot of times the RPR will come up as a false positive. So you want to make sure of that. And if your lab doesn't do that, they really should be doing a confirmatory test. If the drugs are being inhaled, we worry about what's going on in the airways, and that's related to the size of the particles that are inhaled. So the larger particles affect the airways, the smaller particles reach the alveoli. And so some of the complications which are listed there, bronchitis, bronchospasm, pneumothorax, hemoptysis, these are all of concerns. Now for co-occurring disorders, the substance-related problems, third leading cause of death in the U.S. Alcoholism causes 80% of cases of hepatic cirrhosis. 80% of cirrhosis is from alcoholism. Alcoholism increases the risk of pancreatitis, increases the incidence of HIV and sexually transmitted diseases. And here's another statistic. Patients injured while under the influence fill 50% of U.S. trauma beds. So this information comes from the feds. SAMHSA puts this information out. Now, from the World Health Organization, 7 of the 10 leading causes of disability in the world, if you look down this list, they're all the patients that we treat. 7 of the 10 leading causes. So we see depressive disorder, traffic accidents that are often substance-related, alcohol use, self-inflicted injuries, bipolar, violence, and schizophrenia. So this population are the population that we treat. Severe population. Prevalence information. Now, this is an interesting slide. This slide is actually from a 1996 study, the National Comorbidity Study, and I just really need to change the citation. The numbers haven't changed, so they did another one in like 2010 or 2009, and the statistics are basically the same. So in the general population, about a quarter of the population has a substance use disorder. Now, they include misuse. Not just when they did this, of course, they were using DSM-4, so they're using abuse, dependence, and also misuse. And here's an interesting, scary one. Almost a quarter have a mental disorder. And you think, well, 1 in 4 people have psychopathology. That just doesn't make much sense. But the thing that you have to keep in mind is the highest percentage, and this is one of those trick questions on a psych exam, which disorder is the most common, and most people will pick depression, but that's not true. The most common disorder are the simple phobias. And that's between 12 and 15% of the population suffer from a specific or simple phobia, like fear of heights, fear of closed quarters, fear of the dark, that type of thing, fear of rodents. But those people don't come in for treatment. We call those the disorders of convenience. People learn to avoid what they're most afraid of. So if somebody's afraid of elevators, you know, they're not going to get in an elevator and have a panic attack. They're going to use the stairs, right? So they avoid what they're afraid of, and therefore we never see those folks for treatment, right? And that's 12 to 15% of the population. So if you take that out, if you take 12% out from 22, that leaves 10%. A little less than 10% of the population have psychopathology of some sort. So that's more believable with that. About half of those patients have substance use disorders, and about half of patients with substance use disorders also have mental disorders. The classification system, the feds came out with what they called the quadrants of care. And basically, and this is a little bit crazy, I took this right from one of their tips, actually, and they're looking at people with increasing severity of alcohol or other drug use and or mental illness. And so we have 4 categories, 1, 2, 3, and 4. Lower left-hand corner is category 1. So these are patients who have mental disorders that are less severe. So the whole purpose of this is, where should these patients go for care? That's what the feds are trying to do with this. And they said category 1 patients, those that have, mild mental health disorders, mild substance use disorders, they should be treated in primary care. Category 2 are those people that have more severe mental disorders, but a lower severity of substance use. They said, send those people to the mental health system. Category 3, top left, mental disorders are less severe, but substance disorders are more severe. They should be treated in the substance use arena. And then we have category 4, and I can't believe that the Fed said this. Those folks that have more severe in both mental and substance use disorder, basically send them to jail or the ER. Well, that's the very things that we don't want to do with this population, and here the feds are putting it in writing. This is what we should do with this population. Send them to the ER. Well, the ERs, they're doing their best to try to divert people to where they belong, and jail is certainly not the right place for these people. So I only show this to show how stupid, how crazy the feds can get with some of their nonsense with this. So hopefully we have people that don't really follow this. Remember I said that today the belief is that any door the patient goes in, they should be able to get equal treatment, whether it's the mental health door or the substance use disorder door. What we're seeing that now in reality, if the substance use disorder dominates, the patient enters through a chemical dependency program, and usually they don't get their mental health needs met. So when they leave, their mental health issues increase, and that causes relapse a lot of times. If their psychiatric disorder takes priority, then they go into the mental health clinic or hospital, in which they get good counseling and medication for their psychiatric symptoms, but they don't address their substance use issues. So when they leave, they haven't changed anything. They continue to use their substances and then stop taking their medications, and they just spiral downward. So the models of care that are out there now, we have several models. We have the parallel model, which states that the patient receives treatment for the psychiatric disorder in one system and treatment for the substance use disorder in another system. This has been found not to work because the two systems don't communicate with each other. So, and I see this all the time. Patients will go to their mental health provider. So let's say they have a psychiatrist, but they have substance use issues, so the psychiatrist sends them to us to deal with that. And we do, and then we refer them back to their psychiatrist because they already have that psychiatrist. And the patient will say to the psychiatrist, they told me, my counselor back at Living Green said, it's okay for you to give me Xanax. And rather than picking up the phone and calling, the psychiatrist says, if they said that, fine, here's your prescription. So they don't communicate with each other, and our patients triangulate. They do staff splitting with this. So although it can work if there is good communication, but usually there's not. Then we have the sequential model of treatment, and this focuses on stabilizing the most acute disorder first, then addressing the other disorder. Now, sometimes this is the way it has to go. If we have a patient that has schizophrenia and a heroin and cocaine disorder, they stop taking their antipsychotics and they become floridly psychotic. We need to control their psychosis before we can do anything else. So there, a sequential model is absolutely necessary for the health and welfare of the patient. So it's always about harm to self or others that dictates how we treat. So there are times when the sequential model should be used, but not to the extent that it's being used today. And the model that the feds want us to follow is called the integrated model, and it's viewed as the most effective model because we should be treating, no matter what door the patient goes into, both disorders, mental health and substance use. Okay, now the relationships between chemical dependency and psychiatric illnesses, there's many forms that they can go through. So the first one is that the drug use increases the risk of developing a psychiatric illness. Okay, so we see that in fact, there's a 4.5 times greater risk of somebody that chronically is using substances to develop a psychiatric illness. Alternatively, psychiatric illness increases the risk of developing a chemical dependency. We have patients all the time that come in and tell us that, now whether it's true or not, I don't know, but they'll say, you know, heroin stops my hallucinations.